Hello, everyone. Thank you very much again for joining the ventilator round tonight. So we have Dr. Corella. His presentation today is on lung and diaphragm protective ventilation. This is a webinar and we'll keep questions and answers until the end if you have any. So as always, we look forward to your questions at the end. For next week then, next week, Thursday, October the 20th, we have a presentation on systematic approach to high pressure alarm on the ventilator. So next Thursday, October the 20th. And I also wanted to highlight just before we begin, you can register for these events. And when you register, you can choose to support ICU Reach if you wish, and if you're able to do so. Through the process of registration, there is a box that you'll see, a field that asks you to write a price. So that is something you can do. But of course, if you enter 0, that's no problem, and it will still work and it will still allow you to be part of the event. And just as always, we really do appreciate the silver and gold supporters of the work and appreciate you all being here. So I'll hand over to Dr. Corella.
Thank you, Jenny. Welcome everyone. Bismillah ar-Rahman ar-Rahim. So today's topic is going to be on lung diaphragm and protective ventilation. And we're going to be discussing first the principles of protective ventilation, and then we'll go over the lung and diaphragm injury, and then we'll present the different tools that we have in terms of monitoring, and we'll end with ventilator strategies and some pathways that are recommended. But before we start, I would like to have this question answered. So Jenny, if you can put up the question in the poll. And the question is, which of the following can help in mechanical ventilation monitoring for lung and diaphragmatic protection? It's multiple choice, so choose whatever you think is appropriate. Choices are ventilate, and again, it's for lung and diaphragmatic protection. So protective pressure and flow, esophageal pressure, expiratory occlusion pressure, and P 0.1, and inspiratory occlusion, and diaphragmatic fraction of excursion. We'll give it another 15 seconds, and then again, the question is for the lung and diaphragmatic protection at the same time. Okay, so let's get the results. All right, so we have kind of interesting, because I thought everybody is going to put ventilator pressure and flow, which is the volume, and this is the basic of lung protective mechanism. Anyhow, let's get started with the topic. And the first thing I'm going to be talking about is protective ventilation principles. You all heard the term stress and strain. I'm not sure if everybody understands what these terms mean in terms of protective lung strategy. Stress in principle is the pressure applied on the area. You can see that this person is exposed to some pressure from his boss, let's just say. The strain is the resultant deformation, his reaction to that stress, and you can see how he reacted. If we want to apply this to the lung pathophysiology, stress would be the transpulmonary pressure, and strain would be the change in the volume, of course, relative to the functional residual capacity, and not only the volume, but also the shape. how are we changing that volume. And you can see that this is a normal lung. You can see inspiration and expiration. On the right side, you can see those alveoli. What you see on the right side is very low alveolar strain. Those alveoli are inflating minimally in inspiration, so the strain is very minimal. Compared to this one, take a look on the left side, and you will see that we'll get to the left side if it works, but the right side you can see the changes in the volume. You can see how big or how inflated these alveoli are with inspiration. And if this gets to work, actually, you will see that it is inhomogeneous. Areas of the lungs that are inflated, other areas that are collapsed and consolidated. And this is the problem with ARDS. As you see here, this is a CT scan, and you can see in the background here, the red area is the area that represent the alveoli that are collapsed, that are consolidated. So in order to open these alveoli, you would really need high pressure. Most of the time, the pressure that we put on the ventilator do not get to open this alveoli. The blue part of the CT scan here represents the areas of the alveoli that are collapsed. And those are usually easier to open. We can put some pressure, we can open those alveoli. However, if you don't put enough PEEP, they will close again. And this is the nature of the atelectatic trauma. You need to open these alveoli and keep them open. The most significant part of this diaphragm is the normal lung, actually, because this normal tissue have normal compliance. And the pressure that we put on the ventilator would preferentially go to these areas. So the same pressure or the same tidal volume that you put on the ventilator in a healthy lung, it will go smoothly inside the lungs and open these alveoli in an even way. However, in a diseased lung, in a baby lung of ARDS, the same tidal volume will go into the healthy alveoli, will open up more than the diseased alveoli. So you can see the same tidal volume can result into different effects on the alveoli. And this is where the question of whether there's a difference between what we call lung tidal volume and alveolar tidal volume. The lung tidal volume is what you see on the ventilator. However, the alveolar tidal volume, there is no way you can actually see it with the current methods that we have. And this is what, if anything, that was remarkable in critical care science and literature over the past 25 years is protective lung strategy. And we all now follow this very meticulously and strictly. And when we ventilate someone with ARDS, in our minds, we put this PV curve, and we have this lower inflection point and the upper inflection point. If we put a pressure lower than the lower inflection point, we end up having alveolar collapse. So the first principle is to avoid end expiratory alveolar collapse and avoid atelectatic trauma. We do this by applying enough PEEP in the system, and we decide about how much PEEP. There are different methods. We're going to be talking about that in future sessions. But for now, the principle is we need to avoid collapse of the lungs. At the same time, we need to avoid going up higher than the upper inflection point by avoiding excessive and inspiratory alveolar pressure, and that's by limiting the plateau pressure. And as per ARDS network, that pressure should be less than 30 centimeters of water. And in between the upper inflection point and the lower inflection point is the driving pressure that we need to keep less than, preferably less than 15, but if you cannot, at least it should be less than 18. And the tidal volume should be limited to 4 to 6 ml per kg of ideal body weight. This way we provide protective lung strategy with low tidal volume that prevents volley trauma, limited pressure that prevents barotrauma, and appropriate PEEP that prevents atelectotrauma. And of course, the driving pressure also prevents volley trauma and barotrauma. And we've been concentrating too much on the lungs, and we try to avoid very excessive stress on the lungs in order to limit the ventilator strain that can result because of this stress. And the formula that you should be all aware of is that the driving pressure is related to the tidal volume that we put on the ventilator and to the compliance of the respiratory system. If the compliance is low, you need too much pressure to get the volume in. And it's better to talk about the dynamic transpulmonary pressure, and we'll explain this in the next few slides. But you don't need to limit your views of protective lung strategy to what's happening on the ventilator. You need to see what's happening on the patient side also. And that's why I changed this driving pressure to transpulmonary pressure. And we usually go with the dynamic, meaning that if we do the dynamic, we're going to include the resistance, but I'm not going to be talking about that concept at this point. Just wanted to say that let's just think about changing in the driving pressure minus changing in the esophageal pressure is the true driving pressure for the air. And that is related to the tidal volume and respiratory system compliance. If we put it this way, that means that we're putting another factor, which is respiratory efforts. When we put the esophageal pressure changes, that means we're looking at the inspiratory efforts of the patient. And this is actually the bulk of what we're going to be talking about today. So let's take this example. Try to understand why this is very important. So if you take a look on the right side here, you have a patient on ABV-CMV, which is essentially PRVC. And the target tidal volume is 280. So this is very appropriate tidal volume for protective lung strategy. Okay, and you can see we have appropriate PEEP, sort of. And patient is on 90%. He can go up on the PEEP a little bit. And the rate is very fast at 40 per minute. Okay, so forget this is, let's take a look on the pressure. The pressure is 20. It's not high pressure actually. It's very non-compliant system, but it's not that severe. I think we can open up some alveoli with more PEEP here, but this is not what I wanted to discuss. What it looks like, this patient is actually delivering the 280. However, take a look on this one. The tidal volume that is delivered is 512, which is way higher than your target. How did that happen? In a system that the compliance did not change, the PEEP did not change, the ventilator pressure did not change, the resistance did not change, and you can see that this is associated with increased flow and increased tidal volume. The only way this can happen is by contraction of the respiratory muscles. So the patient is contributing to the delivery of the air. And you can see when he uses the muscles, he ends up getting higher tidal volume. Then what is the target for protective lung strategy? So this is not protecting the lungs here. And that's why it's very important to take a look on how does the injury happen. I'm going to present this. I'm going to use some new terms actually. They may look complicated, but I'll try to simplify them. And this is the famous slide that I always present. When you have a patient who's on the ventilator, you need to think about it as dual pump system. There are two systems at the same time working. You're pushing the air under pressure here from the ventilator, and the patient is also inhaling by contracting his inspiratory muscles. So the aim on the ventilator is to optimize the ventilator pressure and volume, and this is protective lung strategy, in order to limit the lung stress and lung strain. And also, we need to avoid diaphragmatic injury, and we'll see that in the next slide. So the aim on one side from the ventilator is to prevent ventilator-induced lung injury and ventilator-induced diaphragmatic injury. On the other side, you need to think about the patient's inspiratory efforts, and you need to optimize the patient's inspiratory efforts to avoid lung and diaphragm injury, while of course maintaining acceptable respiratory hemostasis. And this is what we call the patient self-inflicted lung injury. We need to avoid having patients self-inflicting their lungs with injuries, and also limiting the diaphragmatic injury that may result from patients' efforts too. And those are actually understood if you understand the different types of ventilator-induced diaphragmatic dysfunction. And this is a new term that is introduced into our into critical care, which is VIDD. Now, you don't have to, this slide looks complicated here in terms of the pathophysiology, but I'm going to try to simplify it here. We have 4 different types of myotraumas. So of course, we're looking at diaphragmatic injury, and it's called myotrauma. And we have 4 different types. If we over-assist, meaning that we take over everything, and the patient is not breathing, we end up with disuse atrophy. And this is well known to everyone. This is a common cause, well studied in the literature. On the other hand, if we under-assist, you set the patient on ventilator settings that are less than what he needs. He's going to do the job for you. If you do not rest the patient is going to exert the muscles, and he's going to end up with what we call load-induced. You put a load on the patient, load-induced myotrauma. This is a very probable contributor to diaphragmatic injury. And the third type of injury is called eccentric myotrauma. A bit complicated concept, but simply it is contractions during expiratory phase. So in expiration, the diaphragm should be rested. The fibers should be elongated. What happens here is you put contractions on it. And this is actually coming from the asynchrony with the ventilator. Okay? This type of myotrauma is eccentric myotrauma. And the last one is called longitudinal myotrauma. It's actually because of the PEEP that we put on. If you do not put enough PEEP, you end up making those fibers longer. So you maintain the diaphragm at a relatively shorter length by the application of appropriate PEEP in the system. If you do not put appropriate PEEP, those fibers are going to be a bit elongated actually, and this is what we call longitudinal myotrauma. So this is potential contributor, but this is probable and this is possible. So probable is more than possible in English words. And this is more complicated now. I want to spend some time here. What I want you to know is just the concepts. Why are we thinking this way? Why are we so much interested in knowing how the patient is breathing at the same time? Okay. So I separated this diagram into 2 sections. One on the right side, which is the ventilator, and one on the left side, which is the patient. And if you don't put this adequately, you're going to end up with ventilator-induced lung injury, which is VILI. And if you have problems with respiratory drive and efforts, you're going to have patient self-inflicted lung injury. And both will contribute to diaphragmatic injury. So I'm going to go one after one slowly so you can capture the concept. You're all aware of high tidal volume, high pressure. If we put high tidal volume, high pressure on a baby lung, and baby lung meaning ARDS patients, the results is trauma and barotrauma. And we all know this, we just explained it. Okay. And similarly, if we put too much PEEP, we overextend, we overdistend the alveoli. This is an injury also. On the other hand, if you put insufficient PEEP in the system, you end up de-recruiting. And this is atelectasis trauma. And this is well known already. Now the new terms here, I'm going to start with the simple one. The over-assistance of the respiratory system or over-assistance myotrauma. If you do not use the diaphragm, you end up with disuse atrophy. This is injury to the diaphragm. It's caused because of excessive inadequate ventilator assist. Similarly, if you put excessive PEEP, you end up with longitudinal myotrauma. The one in blue is actually that we still, the work is still in progress. We're not very confident that this is major contributor. That's why I put it in blue. On the right side and the left side, you can see that here. The ones in black are confirmed. And then we have eccentric myotrauma because of insufficient PEEP. And normally we have what is called expiratory braking. And the reason for that is, and this is any normal person has to keep some physiologic PEEP in the system. So we don't exhale all the way, so we cause some atelectasis. And when we have patients on the ventilator, if we do not put enough PEEP in the system, we end up having a lot of expiratory braking. And if that means that we're having, take a look here, we're having exhalation and inhalation at the same time. So this is where it comes eccentric. The word eccentric meaning different directions. It can have a lot of other meanings too. But in concept of diaphragm is a movements of the diaphragm that is not going the right direction. So that's on the right side. If we have excessive or inadequate ventilator assist, we end up having those injuries. So on the left side, if we have a patient who has excessive respiratory drive and has excessive efforts, well, number one, he will do the same thing as the ventilator is doing. This is going to cause breath stacking, dysynchrony. He's going to generate large tidal volume. All those are injurious efforts to the lungs. So he ends up having trauma and barotrauma. And we've seen those patients actually with COVID. At the same time, if the patient is working against the ventilator, if he's having, for example, reverse triggering, and reverse triggering is actually diaphragm triggered because of the ventilator, so it's not patient's effort, I may need to move reverse triggering to the right side. But anyhow, let's just talk about it so we can understand the concept. If the patient has ineffective triggering or premature cycling on the ventilator, we end up having eccentric myotrauma, which is expiratory dysynchrony. Dysynchrony during expiration, movements of the diaphragm in different directions than what it should be. This is eccentric myotrauma. And at the same time, if we do not assist enough, we're going to have load-induced myotrauma, or maybe the patient has excessive efforts. At that time, he has high efforts, high drive, or if you're not sedating the patient very well, you end up having load-induced myotrauma. So those are the pathophysiological concepts. What we aim to do in the ICU for those patients, number one, minimize baby lung stress and strain, and number two, optimize diaphragmatic efforts and synchrony. That's why it's very important to understand how we desynchronize with the ventilator. The third part of the talk is going to be about monitoring. It's going to be, I already discussed some of this in our ventilator rounds, so I'm going to go over those quickly, but you understand now why it is important to monitor those things. It's because of all what we talked about in terms of the ventilator injuries caused by the inspiratory efforts of the patient. But I'm going to put that in a very nice diagram here, and you can follow me from the center here. So we're going to start from the brain. We have the respiratory centers that have impulses, and those impulses will be transmitted through the phrenic nerve, and they will cause what we call electrical activation of the diaphragm. So this is only the electrical activation will result into mechanical activation of the diaphragm. At the same time, the respiratory centers are affected directly from the lungs by different receptors. So they have a direct effect on the respiratory muscles and the mechanical activation of global respiratory muscles, including the diaphragm. Then we have changes as a result of the contraction of the inspiratory muscles. The thoracic cage becomes larger, and then the pressure goes down in inspiration. And we'll have changes in the intrathoracic airway pressures. So what monitoring interventions or what monitoring tools that we have for those patients? In terms of the respiratory centers, it's an indirect way actually. It's an occlusion test, which is the P0.1. The pressure in the first 100 milliseconds of inspiration. We don't have any monitoring tool for the phrenic nerves. We have stimulation tools, and we'll touch on that briefly. But we are able to monitor the electrical activity of the diaphragm by introducing a special probe in the esophagus and measure the electrical activity of the diaphragm. Then we have the ultrasound, and we're able to look at the diaphragmatic muscle. Okay, sorry. And then we can put a special probe to measure the esophageal and gastric pressures, and from this we'll be able to look at the esophageal pressure time product. And finally, for the changes in the intrathoracic airway pressure, we can put inspiratory hold and expiratory hold and get the occlusion pressures. And this way we can estimate the muscle pressures and the muscle index, the pressure muscle index, PMI. So, for those people who are saying that, well, we don't have many of these tools, I'm going to present things very simply that you can do on any ventilator, and you'll be able to understand what's happening with your patient. But just put this in your mind, that you have a center that you need to assess, you have the diaphragm that you need to assess, and you have changes that occur as a result of contractions that you need to assess. And let's just start with the respiratory center. And this is, as I said, is a proxy. You can measure the decrease in the pressure. When the impulses get into the diaphragm, the first thing that happens, of course, the muscles contract, and then the pressure inside the chest goes down. Now, the first 100 milliseconds are very critical because they are not related to changes in the resistance or the compliance of the system. They are directly related to the strength of the stimuli to the diaphragm. And this way we can indirectly understand what happened at the respiratory center. So having a high P 0.1, meaning that it is more than 5 centimeter of water, and in the literature, anything more than 3.5 centimeter is an indication that we have high respiratory drive. But it could also be an indication that you're not providing sufficient level of support. So if your settings on the ventilator are not good enough, at that time the patient is going to do the work himself, and the respiratory drive is going to be stimulated, and you will see that the P 0.1 is elevated. So this is what we see in under assistance. And of course, if you have high respiratory drive, you're not sedating the patient adequately. And if you wean the patient, it's associated with higher rate of weaning failure. On the other hand, if the P 0.1 is less than 1.5, and in the literature you will see some references will indicate 1.3, others will indicate 1 or less. So, you need to understand that those numbers are not very specific. Okay? And you need to, number one, repeat the maneuvers multiple times, and to get an idea about your patient. If everything is actually most of the time, the P01 is above 3.5, that patient's respiratory drive is at a higher side. What you really need to see is a value of 1.5 to 3.5, which would indicate that the patient is appropriately sedated and has appropriate level of support. At the same time, his respiratory drive is adequate. If it is less than 1.5, the respiratory drive is low under the effect of medications or intoxications, or the level of support that you're given from the ventilator is too high. That means you're over assisting the ventilator. So let me give you an example here. So you have two patients, pressure support of 14 on the right side, pressure support 7 on the left. You can see that the P 0.1 is 3.8 on the left. And it means that, well, the support is not enough for the patient. On the right side, it's 0.8, meaning that probably we're giving too much pressure support for the patient. So you can adjust the ventilator settings based on that. The second thing that you can look at is the electrical activity of the diaphragm. And of course, you need a special catheter for this that you may not have at your ICU, but just give you the idea. We're looking at the contraction of the on the electrical activity of the diaphragm, meaning that this is inspiration on the left side and expiration of the on the right side. Increase in electrical activities, and then decrease in the electrical activities. And of course, we're interested in the peak integral of this activity, which is inspiration. And if you take a look on it here, you can see that if this is what's happening with the patient, this is what you see. Take a look on what's happening in the muscles. You will appreciate that the electrical activities ends here in the middle of the inspiration, in the inspiratory time of the ventilator. So this is the inspiratory time on the ventilator. The ventilator is triggered here. This is the trigger by the patient, of course. You can see the electrical activity increased. The ventilator is triggered here. This is inspiration. However, the patient ended inspiration here. The inspiratory time on the ventilator did not end yet. And you can see we're going to be talking about this. This is the esophageal pressure that is correlating with this electrical activity. So this is the inspiratory time for the patient, what we call neural inspiratory time. The target that we aim for is 10 to 20 microvolt. Okay, some references will go up to 22. If you have this, it's not actually well studied, but I'm going to give you targets anyway. So the target is 10 to 20 microvolts. And you can see in this patient here, this is the electrical activity of the diaphragm. And in this breath here, for example, the electrical activity is 5.5, less than what's our target of 10 to 20, meaning that the respiratory drive for this patient is diminished a little bit. Compared to this patient, you can see this breath here, the peak electrical activity of the diaphragm is 17, which is within the target between 10 and 20. The third thing that you can look at, and you all have this, or I hope all of you have ultrasounds in their ICU, you can take a look on the diaphragmatic excursion. And you need to understand excursion meaning movement. And you can do this with the subcostal approach. Look at the diaphragm, and this is the diaphragm here, and you can see the displacement of the diaphragm. Of course, the ventilator, you cannot assess whether this is happening because of the patient or the ventilator. So you need to make sure that the patient is taking a breath, and you measure this excursion while the patient is inhaling with his inspiratory efforts. You want this, there's not much studied in the literature, but anything less than 1 centimeter indicates that the patient has severe weakness. In this patient, you can see it was 1.96 centimeter, and this is spontaneous efforts of the patient. The other thing that you can do is you can look at the thickness fraction of the diaphragm. And this is done with the lateral approach between the anterior axillary line and the middle axillary, anterior and the middle. And you look at the diaphragm, you can see that the pleura and the peritoneum. In between is the diaphragm. It's usually 3 lines, very easy to get. And you can look at the difference between inspiration and expiration. So you measure the end inspiratory thickness, you subtract the end expiratory thickness from the end inspiratory thickness, and you divide by the end expiratory thickness, you get the thickness fraction of the diaphragm. The target is that we need it more than 15%, but less than 30%. In some references, you see up to 40%. Then we can look at the esophageal and gastric pressure. And again, you need the catheter, you need esophageal probe inserted to look at the esophageal pressure. Here we're looking at the esophageal pressure. This is the drop in the esophageal pressure. And I'm going to explain this in the next slide. At the same time, we're looking at the gastric pressure. And you can, of course, if you have a measurement across the diaphragm, you can have the transdiaphragmatic changes in the pressure, which is esophageal pressure minus gastric pressure. Now, when we take a breath, this is spontaneous breath. We contract the muscles and we decrease the pressure inside the chest. And this is the pressure that is generated by the patient. So take a look on it. The patient generated a decrease in the pressure here, but he did not start flow till later. Why? Because he has an auto peep. So this is onset of inspiration. However, onset of expiration onset of inspiratory flow is delayed. And the reason is because the patient has intrinsic peep. So he needed to overcome that intrinsic peep first. And of course, there's a chest wall recoil pressure that needed to overcome also. So you can see that this is the first part that we need to overcome. And then you have the resistance of the airways. This is similar to what we see on the ventilator, but this is happening because of the patient's inspiratory efforts. Resistance multiplied by the flow. This is what we need to overcome. At the same time, we have the elastance of the lungs and chest wall. And this is elastance multiplied by volume. The more volume we need to get, the more pressure that we need to generate. And this is the end of inspiration, and you can see the pressure goes down to the 0 line. If we have esophageal pressure monitor, the target is the change in the pressure is between 5 and 12. Of course, it's a minus value for the pressure. So you need to see not more than 12 centimeters of water change in the pressure between inspiration and expiration when you have the esophageal pressure monitor. At the same time, you can get the area under the curve, and you get what we call the pressure time index or something. Let me just see, product, pressure time product, and that target should be 50 to 200 centimeter water per second per minute. And now this is an enlargement of what I just talked about. If the patient is doing the work for the breath, he needs to overcome any intrinsic PEEP, the chest wall recoil, the elastance of the lungs, and the resistance. And all together will form the pressure time product for that breath. As I said, it should be between 50 to 200. Anything more than this or less than this is extra efforts or less efforts. If we plot the pressure against the volume multiplied by the pressure, and this is again spontaneous breath. If we multiply volume by the pressure, we get the work of breathing. I'm not going to go into details, but that work of breathing should be around 0.2 to 0.9 joule per liter. The last thing, we have some maneuvers that we can do to see what's happening in the intrathoracic pressures. And those are the inspiratory and expiratory occlusion pressures. So we have two different types of occlusion methods, and we talked about one of those in our ventilator sessions, and expiratory occlusion and inspiratory occlusion. I have both done on one patient here, and I'm not going to go into details. We're going to dedicate special sessions, but I'm going to introduce the concept of inspiratory occlusion maneuver. If we occlude the inspiration and the peak pressure goes up from the peak to higher pressure, which is plateau. As you all know, the plateau is lower than the peak pressure. But if this what happened, the plateau is higher than the peak pressure, it means that the patient generated so much intrathoracic pressure with a breath delivery here. When you held the breath, at that time, the plateau needed to go up higher to keep that air inside. On the other hand, you can occlude in expiration and look at the patient. If the patient took a breath, you can measure that occlusion pressure. That occlusion pressure is an indirect measurement of the esophageal pressure. And this is again the occlusion test. This is expiratory occlusion test. Just trying to simplify this for you. This is very important to understand, and we already had a webinar about it or a session, and you can go and watch the recording under education tab. The drop in that occlusion pressure gives you an indication of how much esophageal pressure we have in the system. And usually the occlusion pressure is the esophageal pressure is 2/3 of that occlusion pressure. Because when you occlude the airways, the patient tends to exert higher efforts. That's why in one study it showed that we should only include 2/3 of that occlusion pressure. It will give you an indication of the esophageal pressure. So not only the esophageal pressure can be estimated, but also you can estimate the muscle pressure. And that is related. You can take 3/4 of that occlusion pressure. It may give you a good estimate of what the muscle pressure is. And in this study that we talked about also, you can have it in your ICU where you can do the occlusion pressure. If the muscle pressure, predicted muscle pressure, is more than 13, at that time you need to consider making some changes on the ventilator or modifying sedation for the patient. That means the patient is exerting too much muscles. At the same time, you can look at the esophageal pressure, and from the esophageal pressure, you can look at the predicted transpulmonary pressure. And if that transpulmonary pressure is more than 16, at the same time, you need to make modifications of the ventilator. And I did that on one of the patients here, so you can see how easy you can do it. You remember when you do the occlusion test to check for the auto beep, and this is what you see here. This is expiration. You can see this is a PEEP of 8 in the system here. You can see the patient has some auto PEEP here. And when we occluded the airways, you can see that the pressure went up. Okay? But at the same time, the patient took a breath. And this is what I'm interested in. Yes, this is an auto PEEP, but this is the occlusion pressure that is measured here at 15.7 centimeter. So it's 8 plus 7.7, that is 15.7. So what I do is I take 2/3 of this occlusion pressure. This gives me an indication that my esophageal pressure is around 10.5, a bit on the higher side. This is more complicated now. I may not have time to explain this in details because I need to leave some time for questions and answers. But if you have electrical activity measurement of the diaphragm, you can measure the occlusion pressure and relate this to the electrical activity of the diaphragm. Quickly, the PEEP here is 8. The occlusion pressure, this is the PEEP of 8, the occlusion pressure is -1 centimeter. So the difference is, the pressure that went down to -1 centimeter, so the occlusion pressure is 9 centimeter of water. The electrical activity of the diaphragm, you can see it here, this is 11, but it's slightly before that, it's 12 microvolts, okay? And you can relay the occlusion pressure to the electrical activity of the diaphragm. 9 divided by 12 is 0.75. And this is what we call PEA or P. And then you can estimate the muscle pressure from that. You multiply, this is based on experiments, multiply the P by the electric activity of the diaphragm divided by 1.5, you get the muscle pressure, which is 4.5 here. The target muscle pressure, as we said, 5 to 10. So I put the targets for you here. This is what you need to prevent in any diaphragmatic protection. You need to prevent over-assistance myotrauma by maintaining the muscle pressure above at least 3. As I said, I give you the lower limit 5. 5 would be perfect. Change in diaphragmatic pressure, it should be more than 5. Esophageal pressure should be less than 3, -3, meaning that -4 or -5. The P 0.1 should be more than 1.5. The fraction of the diaphragm, the thickness fraction of the diaphragm should be more than 15%. On the other side, we should prevent under-assistance myotrauma by keeping the muscle pressure less than 10. The diaphragmatic pressure, the change in diaphragmatic pressure, less than 10. The esophageal pressure should be more than 12, meaning that -10, -8. As I said, I gave you esophageal pressure between 3 to 4 up to 10. The P 0.1 should be less than 3.5. The thickness fraction of the diaphragm should be less than 30%. At the same time, you need to prevent eccentric myotrauma by avoiding ineffective triggering and reverse triggering, avoid premature cycling, and minimize expiratory braking. And then we'll talk briefly about, we're going to dedicate more sessions about that. This is evolving evidence in critical care. You all need to be aware that this is what's happening. Now, the goals for protection of the lungs and diaphragm are, number 1, modulate the patient's inspiratory efforts. So we look at what the patient is doing. We need to minimize the dynamic lung stress and strain. This is caused by the ventilator and the inspiratory muscles of the patient. And then prevent or correct patient's ventilator dysynchrony or any form of mismatch between the needs and support, and give the patient appropriate PEEP. In other words, I can actually put things in a clinical physiological pathway. And we can say that number 1, when we put the patient on the ventilator, we need to aim for continuous patient-triggered breaths. So we need the patient to breathe while he's on the ventilator. So you can decrease or stop sedation and opioids as tolerated. You can lower the set respiratory rate for the patient or switch the patient to a mode that can actually support or promote patient-triggered breaths. And this is actually if the patient is, if you're not able to do this, the patient is not breathing, this is future indication for phrenic nerve stimulation. So we assess patient-triggered breaths. Number two, we assess the respiratory efforts of the patient. We measure the P0.1 and occlusion pressure. This can be done on any ventilator. Any one of you can do this, and based on that, you can adjust the flow, the inspiratory pressure, or the rise time of the patient. You can adjust the sedation and adjust FiO2 and PEEP. Then you look at the lung stress and strain. Again, it is the change in volume divided by change of pressure. You can look at the dynamic transpulmonary pressure if you have esophageal pressure monitor. And you lower the inspiratory pressure based on that. You adjust the PEEP based on that, and you monitor for asynchronies. If unable to achieve acceptable respiratory effort or dynamic lung stress, there's a future strategies. We're already doing partial neuromuscular blockade, meaning that we're giving intermittent neuromuscular blockade rather than continuous. We're already doing this. And we have some data about the extraction of the oxygen by extracorporeal extraction of the, not the oxygen, the CO2, but the data is actually so far negative about that. It did not improve outcome. And then monitor adequacy of ventilation, monitor respiratory hemostasis. This is the goal. We need a normal pH and PCO2 and the ability to oxygenate adequately, and then assess readiness for weaning and, sorry, there's a mistake here, and liberation. So you can summarize everything in this slide here. On the right side, minimize baby lung stress and strain. And the left side, optimize diaphragmatic effort and synchrony. So you need to combine both at the same time, and I listed what we have talked about in this slide. You can look at it in different way. You can look at monitoring. We can monitor the airway occlusion pressure in the first 100 milliseconds. You can do the single breath expiratory occlusion pressure, and you can do the end inspiratory occlusion pressure. And if you have electrical activity of the diaphragm, you can estimate the pressure of the muscles. Now, in terms of ventilator settings, which ones will promote more of diaphragmatic protection? Actually, we have data about the proportional assist ventilation, or PBV, PAV or PBS, and NAVA, the neurally adjusted ventilator assist. We can dedicate special sessions about that. We need to adjust the pressures, volume, and flow for the protection of the diaphragm and the lungs, and set appropriate PEEP for the patient. In terms of sedation, you need to address sources of respiratory drive. Is the source peak flow pressure settings? You adjust that. If we have metabolic abnormalities, you deal with it. If the patient is in pain, you give him analgesic agents. And put in mind that opioids can actually adjust the high drive with high respiratory rate. And the propofol will adjust the high drive with high efforts. And finally, we have some adjuncts that need some more investigations in terms of extracorporeal CO2 removal, partial neuromuscular blockade, and phrenic nerve stimulation. With this, I'm going to end with this slide again. So with that in beginning, now concentrate on the green and red. The aim is to optimize diaphragmatic efforts and synchrony. We need to limit the baby lung stress and strain by adequate pressure and flow, the esophageal pressure between 4 and 10, the changes in the esophageal pressure, and we need to provide adequate sedation. We need to avoid eccentric myotrauma, so appropriate sedation and appropriate trigger and cycling. You need to avoid load-induced myotrauma, so appropriate ventilator assist and sedation. On the right side here, we need to limit the baby lung stress and strain and avoid overdistension by limiting the tidal volume and the pressure. Avoiding overdistension by appropriate PEEP. Avoiding de-recruitment by appropriate PEEP, and same thing for eccentric myotrauma. And providing adequate pressure and flow, adequate sedation to avoid over-assistance myotrauma or disused myotrauma. Thank you very much. I can see if there are any questions. We have some time, probably a few minutes.
Thank you, Dr. Carla. Yeah, so I'm sure some of you have questions. We have some time. As always, feel free to unmute and direct your question to Dr. Carla, or you can put it in the chat box.
Jenny, Dr. Ala raised her hand.
Thank you so much, Doctor. It was an informative lecture as usual. And this is the first time I heard about P0.1. But I have one of the question, how it is reliable in the ICU in the literature about, I ask about sensitivity and the specific for this test for weaning.
Yeah, so each one method that I presented requires much more details in terms of explanation and looking at the literature. And you should not rely on a single measurement alone. You need to put things together because each method has its own specificity and sensitivity, and it may not be perfect in determining exactly what's happening in the respiratory drive or the respiratory muscles. So we have good literature to support the pressure in the first 100 milliseconds, but you always can combine with other tools at the same time. I do have a blog written about P0.1 ALA. Go to the website, and I listed the studies that looked at the reliability of the test in terms of the sensitivity and the specificity.
Okay, thank you. We have one in the chat box here, and it says, what is the difference between end inspiratory occlusion pressure and inspiratory holds for plateau pressure estimation?
So what you're looking at, you're holding the breath in different times of the breath. If you hold it in expiration, so you're letting the patient exhale first, and then you're holding the system. And then you're looking at any inspiratory efforts that are actually done during that period. In inspiration, you're holding after the patient inhales. And if the patient is, so you're not letting the patient exhale here. You're holding within inhalation, within inspiration. So of course, if there's no change between the peak inspiratory pressure and the plateau pressure, the patient was not participating in the breath. If the occlusion pressure is higher, which is plateau pressure higher than the peak, it means that the patient participated in the breath, and the difference would be the muscle pressure index. Now, what happens a lot of time, I have a slide actually, we're going to be talking about that. I don't think I have, I'm going to find it easily. But what happens, the patient may also breathe in that inspiratory hold, and you can measure the drop in the pressure in the system. Whether it is inspiratory hold or expiratory hold, the aim is to see or to get an idea about the patient's inspiratory efforts, whether this is happening during inspiration with the ventilator, or during the inspiratory hold, or during expiration. That drop in the pressure is an indication of the esophageal pressure.
Okay, thank you. So how can we assess diaphragm muscle fatigue in a COPD patient?
Well, you know, it's what I presented here is the two different methods. Number one, you need the patient to be spontaneously breathing in order to assess the function of the diaphragm, and you can look at the diaphragmatic exclusion or the displacement of the diaphragm. If the value of that displacement is less than 1 centimeter, that means it's weakness of the respiratory muscles. And you can assess it in COPD patients. It's not different from COPD patients or other patients. And also you can, as I mentioned in the presentation, you can look at the thickness fraction of the diaphragm, the difference between, because when you inhale, the thickness increases. When you exhale, it decreases. So you can look at that percentage. How much is that out of inspiration? And you should aim for 15% to 30 or 40%. If you have thickness fraction less than 15%, this indicates diaphragmatic muscle fatigue, whether it's COPD patient or different patients, the same. Again, the literature is evolving in this. The reliability of those tests is actually dependent on so many factors, including how you're doing the tests. And I do those tests myself. It depends on the angle that you put the ultrasound. You may get different thickness. So you have to train yourself very well in order to get good measurements. Good question. Thank you.
Okay. So someone is thanking you here again for the lecture, and they've asked any strategies you can suggest to attenuate the high respiratory drive other than sedation, increasing flow and rise time?
Yeah, there's sedation and adjustment on the ventilator. Those are the strategies that we have. But make sure that you don't give those patients paralytic agents, because if you give paralytic agents, what you're doing is you just inhibiting the contractions of the diaphragm. You're not inhibiting the improving the respiratory drive. Let's put that question again and see if we can have different answers now. Let's launch the question before we end.
Okay, the poll, let me see. That should be relaunched.
Yeah. So if you read it, the question again, and let me see how you're going to answer it after this. We have 25 people here, so we should get a good number. Which of the following can help in mechanical ventilation monitoring for lung and diaphragmatic? Excellent. Number 1 is good. All right. I see that some of you are probably misinterpreting the first answer, which is ventilator pressure and flow. You always need to monitor the pressure and flow on the ventilator, because what I showed you that the pressure and the flow can determine the respiratory drive for the patient. And of course, can result into adverse outcome in terms of ventilator-associated injury or patient self-inflicted injuries. So let's just give a few more seconds. We have 2 more minutes, actually. I have something to be done after that. Okay, so let's launch the answers, please. Okay, so most of you actually, thank you very much. Is it showing now? End the poll, please. And share results. Okay, I think they are seeing it right now. So you can see that most of you got the right answer. Everything is correct here. So on the ventilator, this is what you need to do. Whatever method you have, you can combine these methods together. Ventilator pressure and flow, that's for sure. And every single patient, you need to know. Of course, depends on the mode of ventilation that you have, whether you're controlling the pressure or the volume. Esophageal pressure monitor, if you have it. Luckily, we have that in our ICU. Inspiratory and expiratory occlusion pressures, as we talked about. This is very simple. You can do it on any ventilator. You can do it tomorrow on your patient. Nothing specific about in terms of preparation for this. And you can measure, I think most of the ventilators now measure the pressure in the first 100 milliseconds. It may be different from one ventilator to another, except the old ones. And then you can look at, you have the ultrasound in the ICU, you can look at the diaphragmatic fraction of exclusion, or the displacement of the diaphragm. And finally, if you have the special probe for the electrical activity of the diaphragm, you can do that. I think we can end here, Jenny.
Okay. So any final questions? If not, that's us for this week. And Thursday the 20th, next week, is our next ventilator round, and we hope to see you there. Thank you, everybody, very much.
Thank you, everyone. See you next week.
Thank you, Mazi.
So Jenny, let's just close it because I need to go. I'll talk with you later. Thank you.